Respiratory physiology. A 43-year-old man presents with upper airway obstruction, which will tend to decrease the movement of gas into and out of the lungs, which is known as ventilation. The minute ventilation is the volume of gas that moves in and out in a minute and is determined by the tidal volume and the respiratory rate. To remind you, the tidal volume is the volume of air that moves in and out of the lungs during quiet breathing. However, not all the volume is involved in gas exchange. Some of the gas goes to alveoli that are not perfused. Because there is no blood flow to these alveoli, they do not take part in gas exchange. These alveoli take up part of what is known as the dead space. The remainder of the dead space is made up by the pharynx, trachea, and bronchial tree. This slide shows the dead space. Thus, the ventilation per minute of perfused alveoli, which is known as the alveolar ventilation, is the tidal volume minus the dead space multiplied by the respiratory rate. Carbon dioxide passes easily from the blood to the alveoli, so the major determinant of removal is the rate at which it is removed from the alveoli, and this is dependent on alveolar ventilation. Thus, carbon dioxide elimination is dependent on the respiratory rate, tidal volume, and the dead space. Returning to our patient, you will remember he is a 43-year-old with upper airway obstruction. Reducing ventilation will reduce the CO2 elimination and hence increase the CO2 in the blood. The respiratory centre in the brainstem responds to increases in arterial carbon dioxide or falls in pH with an increase in ventilation. Similarly, a fall in carbon dioxide or a rise in pH has the opposite result. Nerve impulses from the brainstem pass to the intercostal muscles and diaphragm, causing expansion of the thoracic cavity. As the cavity expands, the lungs are sucked open. This results in inspiration. Thus, the upper airway obstruction in our patient will result in an increased stimulation of the respiratory centre and an increased breathing effort, which will tend to restore the arterial carbon dioxide to normal until the compensatory increase in respiratory effort is insufficient to do so, and the carbon dioxide rises. In the alveoli, oxygen passes into the blood because the partial pressure of oxygen in the alveoli is higher than in the blood. If the patient's compensatory mechanisms are unable to restore ventilation to normal, less CO2 is removed from the alveoli and the partial pressure in the alveoli rises. At the same time, the oxygen in the alveoli is not replenished and the partial pressure of oxygen in the alveoli falls by about the same amount. You can see that a significant fall in ventilation, resulting in a 50% increase in carbon dioxide, has relatively little effect on oxygen. Because of this, hypoxia is a late feature of airway obstruction. Hypoxia due to hypoventilation is easily corrected with low-flow oxygen. As we have said, getting oxygen into the body depends on the partial pressure of oxygen in the alveoli, but also on the relationship between ventilation and perfusion. Normally, ventilation and perfusion are reasonably well matched. However, if alveoli are perfused but not ventilated, e.g. due to collapse or pus or edema fluid, shunting occurs. When this happens, the blood perfusing these alveoli remains poorly oxygenated, with the result that blood leaving the lungs is not fully saturated. Shunting is the commonest cause of hypoxia in critically ill patients. Remember that the aim of therapy is to restore oxygen delivery to tissues, and that saturation, not PO2, is a major determinant of oxygen delivery. Oxygen delivery is the product of the cardiac output, the oxygen content of blood, and a correction factor. The oxygen content of blood is mainly dependent on the oxygen saturation and the hemoglobin, with a very small contribution from dissolved oxygen. As a result, it is the saturation which is important in determining oxygen delivery rather than the PO2.